Hello, my name is Melinda Larner, and this is my DNP project presentation, Body Mechanics Education to Decrease the Duration of Physical Work Restrictions After a Work-Related Back Injury. Introduction. Manual laborers may suffer back injury at work due to not using proper body mechanics. Body mechanics is moving the body in ways that promote balance and efficiency and prevent unnecessary stress on the back. Evidence shows that body mechanics education is effective in reducing pain and injury at work. Moving in ways that are awkward or improper can cause physical strain on the spine. The physical strain can lead to spinal disc and joint degeneration and back injury. Manual laborers such as postal workers and warehouse workers are especially vulnerable to injury as their jobs require a large number of physical tasks such as lifting, pushing and pulling, repetitive movements, standing, and general physical exertion. General posture is an important part of proper body mechanics. Good posture includes standing with feet apart. The tailbone should be tucked in and the pelvis should be tilted forward, which can be accomplished by tightening the muscles in the buttocks. However, when tilting the pelvis forward, one must be cautious to avoid arching the back too severely, which could cause unnecessary stress on the back. The shoulders should be pulled back and the chest should be lifted. The chin should be level, not pointing up or down. Manual labor may involve spending time in a standing position. Along with using proper posture as described above, there are techniques that should be used while standing at work. To relieve stress on the spine, workers should change positions frequently. They should also stand on a firm surface that is level. Leaning on something sturdy can be helpful as the object can support some of the worker's body weight. Even workers who sit for most of their work, such as truck drivers or computer workers, are at risk for injury if proper body mechanics are not utilized. When in a seated position, the buttocks should be at the back of the seat. However, a space should be kept between the back of the knees and the seat. The feet should reach the floor so that they can be flat on the floor and the knees at a 90-degree angle. Similar to good standing posture, the chest should be lifted, the shoulders should be pulled back, and the chin should be at a neutral position, not pointing up or down. Armrests of a chair should be at an appropriate height in order to best support the arms. If a footrest is utilized, the knees should be at the same level as the hips. Furthermore, lumbar support is vital when in a sitting position for a long period of time. Finally, lifting is an especially common cause of back injury at work. It places great stress on the low back. There are techniques for lifting heavy loads that can help mitigate the risk of injury. Placing the load directly in front of the body helps to avoid twisting and incorrect positioning while lifting. The load should be brought close to the body towards the chest. The lifter should bend the knees, assume a squatting or lunging position, and the back should be kept in a neutral position. Tightening the muscles in the lumbar and buttocks can help support the structures in the back while lifting is taking place. While lifting is taking place, the legs should bear the weight from the load, while the back should not. It is also important to avoid lifting from a forward bent position. Background. Work-related injuries are costly. Employees may miss workdays due to injury and disability, and it's possible to injure various body tissues and structures. In the U.S. alone, there were 2,607,900 non-fatal work-related injuries and illnesses in private industries in 2021. Treating work injuries is expensive for both the provider and the payer, and employees can miss workdays as a result of injury and treatment. In 2021, work injuries cost a total of $167 billion, which was $1,080 per worker. The cost per medically consulted injury was $42,000. Total days lost for work-related injuries was 70 million. Musculoskeletal injuries can leave widespread damage, potentially affecting the muscles, tendons, ligaments, joints, peripheral nerves, and blood vessels. Symptoms such as pain, paresthesia, stiffness, swelling, redness, tingling, and numbness may occur as a result. Injuries may cause disability and absence from work and also lost wages at work. In many cases, injured workers are still expected to work, but are assigned work restrictions as they recover from their injuries. Work restrictions may consist of desk work instead of manual labor, or manual labor that is reduced in intensity, such as a weight restriction for lifting. Although employees with restrictions can continue to work, they risk further injury and may operate with decreased productivity. An intervention to prevent work-related back injuries and shorten the duration of work restrictions as a result of these injuries is needed. Research methods. A quantitative cohort design was utilized for this project. Employees with back injuries received body mechanics education, and the average time in days back to full duty at work was compared before and after implementation of the program. Patients were considered for the project according to inclusion and exclusion criteria until as many eligible participants as possible were included, up to 102 total as determined by a power analysis. Inclusion criteria. Inclusion criteria for the subjects to be included in the project were the following. 1. The subject was between the ages of 18 and 70. 2. The subject performed manual labor at his or her place of employment. 3. The patient sought care for a work-related back injury. Exclusion criteria. 1. The patient sought care for a non-work-related back injury. 2. The patient's back injury was work-related but was not the result of manual labor. 3. The back injury for which the patient sought care caused chronic pain lasting more than 3 months. Intervention. The participants were given face-to-face body mechanics education with an advanced practice nurse at an occupational health center/urgent care health center. The participants were encouraged to take the educational materials presented home for further use with the hope of decreasing the duration of their work restrictions and preventing future injuries. The materials included principles and concepts of body mechanics and recommendations for good posture and body control and correct technique while lifting, pushing, pulling, reaching, and carrying. These materials were published and disseminated by another university. This is the second page of the educational materials. Data collection. Informed consent was not required as patient education is a standard of practice. Informed consent was also not required for the pre-implementation phase because the phase consisted of a retrospective chart review of information that was already recorded. There was no interaction with patients for this phase. Patient identifiers were removed from the data. The data collected were pertinent pre- and post-test data from electronic health records. The data points collected were age, company, location of the injury on the body, how the injury occurred, the date of the injury, the presence of physical work restrictions, and the date that the worker returned to full duty. The data from this project was digitally recorded on data sheets that were created for the project by the project author. Data was collected retrospectively and after implementation on these digital data sheets. Data was stored on a password-protected computer. Only the project author had access to the computer on which the data was stored, and only the project author had the password needed to access this computer. Physical data sheets were also used as a participant log by the providers at the facility and were kept in a folder in a locked office that was only accessible to the advanced practice nurses. All patient identifiers were removed. The data points that were collected were the same for both pre and post-implementation groups. Data analysis. There was a decrease in the average time back to work at full duty between the pre- and post-implementation groups, from 28.7 days in the pre-implementation group to 12.8 days in the post-implementation group. However, the sample size was much smaller than desired. The pre-implementation group had only 18 subjects, while the post-implementation group had only 6, meaning that there were 12 missing values in the post-implementation group. Data could not be tested for statistical significance due to the small sample size in both the pre- and post-implementation groups. So descriptive statistics were utilized instead of statistical testing. Also, there were fewer incidents of new back injuries that presented to the facility than originally anticipated, which negatively impacted the ability to achieve the desired sample size. These are the descriptive statistics of the results from the present study. The average number of days that workers were on physical work restrictions in the pre-implementation group was 28.72 days, while in the post-implementation group it was 12.83 days. The shortest duration of restrictions in both the pre- and post-implementation group was 7 days. The longest duration of restrictions in the pre-implementation group was 77 days and 35 days in the post-implementation group. The range for the pre-implementation group was 70, while it was 28 in the post-implementation group. The standard deviation in the pre-implementation group was 22.05, while the standard deviation in the post-implementation group was 11.21. The variance for the pre-implementation group was 486.56 and 125.76 in the post-implementation group. There was a high level of variability in the data set, which may have been due to the small sample size and missing data values between the pre- and post-implementation groups. Again, it was not feasible to apply these statistics to a larger group or population. The results could not be generalized. Discussion. The present study did not acquire enough data to test for statistical significance, as discussed previously, so it cannot be recommended, based on this study alone, that body mechanics education shortens the duration of work restrictions for workers with new-onset work-related back injuries. However, the literature strongly supports body mechanics education. When various organizations were studied, many employees were not using proper body mechanics at work, suggesting a need for body mechanics education. In addition, when patients received brief body mechanics education as opposed to only routine care, there was a statistically significant decrease in severity of pain in patients with a lumbar disc hernia. Similarly, a comprehensive body mechanics instructional video and demonstration of low back rehabilitation exercises showed a statistically significant improvement in mild to moderate low back pain and disability after the interventions were implemented. When giving forestry employees with low back pain an educational booklet was compared to giving them the booklet plus a face-to-face review of it with an occupational health nurse, it was concluded that ultimately the combination of teaching efforts was not more effective than giving the booklet alone. However, giving the booklet alone only resulted in decreased impairment at a 12-month follow-up, while providing both treatment methods resulted in decreased impairment at the 24-month follow-up. Similar to the present study, the booklet contained body mechanics information that was helpful for improving performance of tasks such as lifting, carrying, sitting, standing, driving, and completing desk work. An educational program was found to decrease pain and injury in staff nurses who perform manual labor. Other groups of manual laborers with a decreased incidence of pain and injury were employees of oil and gas installation and hotel workers. In ascertaining why workers may not have been using proper body mechanics, the literature cited body mechanics knowledge deficit as a potential contributor. Studies implemented body mechanics teaching to determine if it would be effective in increasing body mechanics knowledge. It should be noted that the methods of education were different between studies. For example, some used didactic and demonstration methods, while others used video instruction or a self-instructional module. Some used pamphlets or booklets or face-to-face teaching. However, it can be argued that even though varying educational methods were used, all of these studies showed that body mechanics education significantly increased the knowledge of subjects in all of the studies, emphasizing its effectiveness. The consistency between articles and their ability to establish statistical significance supported the intervention that took place in the present quality improvement project and emphasized the need for it. It also added credibility to the body of literature, which guided the development of a safe body mechanics education program. Strengths and limitations of the current study. Strengths: cost effectiveness, and the education may safely continue at the facility. The project author did not incur any expenses while implementing the project by utilizing a free public printer to print the body mechanics educational materials. Should the facility continue to provide these educational materials to patients, the cost will be minimal and directly proportionate to the number of copies printed. Other than printer ink and paper, there are no costs associated with continuing this initiative. Furthermore, from a patient safety and benefit perspective, it is feasible for the providers at the facility to continue using the educational materials after the conclusion of this study when applicable. Although data collection for this project had major limitations, the intervention itself was rooted in evidence. As a result, this study can serve as a foundation for further data collection, and future patients with back injuries can receive the education, which may improve their outcomes. Limitations: small sample size, time constraint on the data collection, and patients canceling appointments or being referred to another facility. The most significant limitation of this study was the inadequate sample size in both the pre- and post-implementation groups. Although the providers at the clinic received education regarding inclusion criteria, it is possible that not every eligible subject was included in the study, as the project author was not present for the entirety of the intervention's implementation. However, to mitigate this potential problem, one of the providers performed periodic chart audits to ensure that eligible participants were consistently being included. Therefore, it is more likely that there was a coincidental decrease in new-onset work-related back injuries during the project's duration. It is also possible that the estimated typical patient load that was reported by the staff prior to the project's implementation was inaccurate, therefore not conducive to reaching the desired sample size. Another limitation resulted from participants not attending their scheduled follow-up visits or being referred elsewhere for care. Some subjects were placed on work restrictions but did not come back to the clinic for reevaluation. Therefore, it could not be determined when or if they went back to work at full duty. To mitigate this limitation, staff could have called participants or sent text messages or emails to remind them about their upcoming follow-up appointments. In other cases, patients remained on restrictions but required care that was beyond the scope of the occupational health clinic at which the project was implemented. These patients were referred to specialties such as orthopedics or neurosurgery, and further data could not be collected. In these two instances, the subjects were excluded from the study, which further limited the ability to achieve the desired sample size. The final limitation was the time constraints of the study related to the project due dates set by the overseeing university. If the study had been allotted a longer period of time, it is possible that enough subjects could have been recruited for the implementation phase. Because of the small sample size, results from this study were not generalizable. It was not possible to apply the results to a larger population, as statistical significance could not be determined. For the same reason, these results could not be considered sustainable. Overall, these limitations heavily affected the sample size, which hindered the validity of the project. Recommendations: implications for future research and implications for nursing. The same study could be conducted again, but over a longer period of time, which would allow for the recruitment of a larger sample size, especially if the patient load at a facility is decreased at any given time. The study could also be conducted at additional facilities in order to ensure an adequate sample size and promote the study's generalizability. In addition, the body mechanics educational materials could be translated into additional languages, which would help all subjects understand the materials and confidently participate in the study. Establishing standard practices in healthcare promotes patient safety and positive outcomes. With the implementation of this education, every worker who presented with a new back injury will receive the same care, an evidence-based education. Healthcare providers can know that they are providing safe, evidence-based care to their patients. Therefore, it is recommended that the site at which the study was conducted continue to provide this education to the patients with these new materials. Lessons learned: ensure that there is adequate time to conduct the study, make educational materials available in other languages, and audit education sessions. The same study could be conducted, but over a longer period of time, which would allow for the recruitment of a larger sample size. The study could also be conducted at additional facilities to ensure an adequate sample size and promote the study's generalizability. There is a significant number of Spanish-speaking patients that receive care at the site where the intervention was implemented. If any patients who qualified for the study did not speak English, it may have been difficult for English-speaking providers to introduce and explain the education. In addition, after contacting the university by which the educational materials were published, it was determined that the materials were not available in any language but English. This could have resulted in some patients being unable to comprehend the materials, leading to the education potentially being ineffective and results being negatively impacted. In these instances, identifying eligible but non-English speaking participants and providing translator services could have prevented a language barrier from affecting the results. Although the providers at the clinic received education regarding the inclusion criteria, as stated previously, it is possible that not every eligible subject was included. The project author was not present for the entirety of the intervention's implementation. To mitigate this problem, one of the providers performed a periodic chart audit to ensure that eligible participants were consistently being included. However, the project author could monitor more closely during implementation with more frequent audits and be present to watch the teaching take place. These are my references for this presentation. Thank you very much for watching.